take-home messages I'd like to leave you with are that bed rest and spaceflight cause hypovolemia, cardiac atrophy, and a low stroke volume in the upright position. Together, these lead to sympathetic activation, prominent orthostatic tachycardia, and orthostatic intolerance. Similarly, POTS is characterized by a small left ventricular mass, a low blood volume, and a low stroke volume when standing. In both conditions, reflex responses appear calibrated to this low stroke volume. Exercise training increases LV mass and expands the blood volume and is quite effective at preventing bed rest-induced cardiovascular conditioning. It also appears to an optimal pathophysiologically based treatment for POTS. And if you'd like to read more about this, we recently published a JACC focused seminar and review in the Journal of the American College of Cardiology. It was published last year, led by Meredith Brierly, one of our fellows, including Steve Renino. This was a joint publication between neurology and cardiology, and it summarizes our key interventions. So with that, I think I'll stop. I'm going to stop my screen sharing, and I'll be happy to answer any questions for anyone who'd like to ask.
Thank you, Ben. That was really wonderful. And you're right, it's always hard when you give these talks. You can't hear people sniggering or at your joke slides and the like. And I did like the last line of the letter, which you didn't emphasize. But thank you for my teeny weeny heart. I thought was a very nice touch. So I'll open up the floor to questions from the audience.
So this is Bill Weintraub. This was really a fascinating talk about something about which I knew very, very little. And I'm so grateful for you to really educating us all today. Perhaps you can tell us, who are the young women who find themselves in this situation in the first place? Are these, can you predict it? Are these young women who have been sedentary for their teenage years and then fall into this? Or is it harder to predict than that?
Yeah, so it is much harder to predict than that. And I think what happens is there are multiple common pathways to POTS. And the typical patient who I see is actually usually a highly functioning person. Often they've been quite active and quite athletic, like the ballerina, and then something happens. They get injured, they get sick, they have some disturbance of their social structure, and they stop training, they go to bed, and then they find when they, even after a short period of time, they get lightheaded and dizzy and they go back to bed. And they spend many, many weeks in bed rest deconditioning. You can get it, some of these patients have, I think probably do have short-term autonomic neuropathies. We've seen that. Steve Renino has measured autonomic ganglionic antibodies in some patients. Some patients do have other medical problems, but when I see them in the chronic state, once that acute medical problem, injury, whatever, has resolved, what dominates their disability is the functional incapacity and the bed rest deconditioning.
So, this suggests to me the importance of getting people up and mobilized, whatever the situation. When I was in training, I'm probably one of the oldest in the group today, and would probably remember a time even before you. When I was in training, we put the people to bed after an MI for 3 weeks. A couple decades before that, people were put to bed rest for 6 weeks. Yeah. When I was a cardiology fellow, we changed all that and started getting people up the next day, which was really the right thing to do. And what it suggests to me is all kinds of chronic conditions that people have, or acute medical problems for that matter, the importance of getting people up, getting them mobilized, and getting them moving. I wonder your thoughts on this.
Yeah, I couldn't possibly agree with you more. I think this is true for patients sick in the hospital. It's true for patients at home. It's true for even patients in the COVID era. The worst thing they can do is spend their entire days in bed. So get upright, be physically active, and it's one of the most important things you can do for your overall health. Exercise is medicine.
I'm going to hit the rowing machine right after your talk.
All right, great.
Ben,
I think you're muted, Samir. You're muted.
Was somebody trying to ask a question on mute?
Yeah, I think Samir was trying to ask a question. I saw his lips move, but nothing came out.
Can you hear me now?
Yes.
Yeah.
Perfect, thank you. I wanted to thank you for this absolutely wonderful talk. This is fascinating. That's the first time I actually begin to understand this syndrome. I've seen several patients over the years with it, and I feel in hindsight that I did such a horrible job of treating them.
Samer, it's hard to hear you. Can you put the microphone closer, maybe?
All right, third time is a charm. I'll just go straight to the point. I have a question about the age part of it. So you tend to see these in young women, not so much in older women. Is that have to do with a lag of the heart hypertrophy over age, or why is it that we see it in young, not older individuals? And in case you didn't,
I think that's a really, it's a really interesting question about, and I'll repeat it if you couldn't hear it. It's related to the age of the patients. These are all young women. I typically, if a patient is postmenopausal, I question the diagnosis. Why is that? I don't know. I don't know if it's the change in estrogen testosterone balance, the change in endothelial function, the change in blood and plasma volume. What we see in the spinal cord injured patients is they get both vascular and venous and arteriolar atrophy, so that surprisingly, patients with spinal cord injury can sustain upright tilt because of the extraordinary vascular atrophy that occurs. And I haven't come up with a great answer. It may be that the deconditioning with older age is slower and less dramatic, but we just never see it. I think this in older women ever.
Thank you.
Dr. Levine, thanks so much for this talk. This has been one of the cardiology fellows. I have a question. I've read that POTS has an association with certain mood disorders, such as depression and anxiety, and I was wondering if that's something you've seen in your group of patients that you've studied, and if you have any hypothesis for why that association may exist.
So I would say this, the data on anxiety in POTS is not compelling. Many of these patients actually don't score highly on anxiety scales. There's some nice data from the Mayo Clinic from Mike Joyner's group showing that. The problem is there's no doubt that there is some, let me call it psychopathology. It really is a hypervigilance that dominates much of the symptomatology. And I wonder how much of this is actually neuroplasticity related to deconditioning. For example, you all know what the runner's high is, right? The feeling of whether it's endorphins or other pain sensing downregulation with intense athletic training. I think the opposite happens when you put people to bed. And we've seen that in bed rest studies. People become very pain sensitive. And so we're working with a group from UTD who have taken muscle biopsies from our bed rest patients and are looking at various proteins in the brain that are upregulated, that are involved in the pain pathway. I think that this is part of the problem with the whole syndrome, that the extraordinary hypervigilance. And they're not all crazy. I think they really do feel all these things they say they feel. And for most of us, it doesn't pass through the gate. We don't sense it, but something happens and their pain sensitivity increases. And with exercise training, it's one of the few things that we know of that can cause, release of brain-derived neurotrophic factor, increase hippocampal volume, alter brain structure. And I think it's one of the reasons the patients feel better, not just from tamping down the hyperadrenergic state, but also by changing the neural architecture.
Ben, you were talking about the exercise, and you always talked about it sort of, or for the most part, in the sense of LV mass. And this may be a question based from ignorance more than anything else. We know that different exercises, weightlifting versus aerobic exercises have different effects. So is the change in LV mass that the heart, that your LVEDP is going up because you have a larger heart? Is it wall thickness? Is it any exercise will work, or does it have to be a specific kind of exercise? When you say small heart, what exactly do we mean by that?
Right. So if we look longitudinally, when I put people to bed, the first thing that happens is you lose volume. So LV volume goes down. And then if you look at mean wall thickness doesn't change, or it goes up a little bit. But then over time, you start to remodel, and LV volume doesn't change so much, but you now, wall thickness goes down. And so I think it is a combination of, let's call it eccentric atrophy. And so I think the best way to approach it is, that's why I like rowing so much, because it's both combined strength and dynamic exercise. Each time you pull on the oars, you have a big increase in arterial pressure. Mean pressure is 250 millimeters of mercury. For each pull, you've got a large muscle mass. And so we incorporate strength training. I think it's a combination of strength and dynamic. Any rational exercise program includes components of all of the above. And I think you want to build both the plasma volume and the muscle mass of the heart. I use mass because it's an easy indicator of atrophy and hypertrophy, sort of the defining value that we look at. But I think that the time course of changes in mass and volume are different. And we saw that in our training also, in our longitudinal training study, which we published in Circ a few years ago. We saw with a purely endurance training program, increases in wall thickness before we saw increases in volume. So wall thickness first, and then we only saw the eccentric hypertrophy after we included longer duration sessions and high intensity sessions.
Any other questions? For the sake of time, maybe just one or two more at most.
I have a question. Can you hear me, Gabby?
Yes, Rob, you're on.
Hi, thanks so much for a terrific lecture. One question you mentioned, you touched just very briefly on the syndrome of inappropriate tachycardia. Yeah. And I think very elegantly described why POTS has a syndrome of appropriate tachycardia. Trying to determine and trying to separate out those patients who have symptoms of inappropriate tachycardia and the whole morass of also neurocardiogenic and vasodepressor syncope is obviously why we need people like you to help clear it up for us. But when it comes to the syndrome of inappropriate tachycardia, what are the things that help you mostly to differentiate?
For me, the single most important thing is tachycardia in the supine position that does not slow down at night. So heart rate is a function of three things, right? It's intrinsic heart rate, phase 4 depolarization. Are you an electrophysiologist, Rob? No. So phase 4 depolarization in the sinus node plus the balance of sympathetic and parasympathetic activity. So that's what controls the heart rate, And so which component of that do you think is off in inappropriate sinus tachycardia? And so it's mostly vagal withdrawal. And I think these are patients who have supine tachycardia and don't slow down at night. That's what I use. And I think it's relatively rare. The upright tachycardia, in our experience, is explainable by a low upright stroke volume and redistribution of the blood. Now, neurally mediated syncope is a different, whole nother discussion. I focus mostly on the orthostatic components of this. But I don't know if you read my On My Mind piece that I wrote in Circulation early last year, which is abolish the tilt table test for the diagnosis of syncope. And we got a lot of pushback about that, but that's the purpose of those things.
Excellent. Well, Dr. Levine, thank you so much. That was really a brilliant talk, and I really appreciate you coming out. And I guess we have to start the Georgetown Fellowship Rowing Club sooner rather than later.
All right. Well, thanks very much for your attention, everybody. And fellows, please feel free to reach out if you have any questions.